Hey guys, good evening. Can you all see me and hear me? Give me a quick confirmation if I am visible and audible to you. Sorry for that delay. It's been raining heavily here and there are some connectivity issues. So just a heads up in case some issue happens. It's the rain which is at fault and not me. So just give me a confirmation if you can see me and hear me fine and audio visual is good. If the volume is a bit low, I'll try and be louder. It must be the background rain again. So this is the session that is left from integrated cardiovascular system. We've done the other systems over the last few weeks. My name is Zainab Vora and I've done my MBBS and MD in Radiology from INICET New Delhi. And today we want to discuss a bunch of topics from cardiovascular system which I feel are important for INI-CET point of view. So we want to discuss a few lines and tubes and how they appear on X-ray and a few recent advances on that. Can you all see me and hear me, guys? Okay, so just give me a confirmation of that. I think I can see your comments now. So yeah, that is what we want to do. We want to see a few instruments. We want to see coronary artery anatomy, and we want to look at cardiomyopathies and their imaging features, and also we want to talk about congenital heart disease. All right, so in around 30 to 40 minutes we want to get all of this done. Okay, so let's begin then. I'll just post the PDF Ruhi after the class is over. Is that okay? So I'll just post the annotated version for you. Okay. So you know about the Plus subscription, and now you can combine it with Iconic subscription, where you can also get access to Prep Ladder, where you have recorded lectures. Alright, so you get best of both worlds if you get Iconic subscription. And these are the various batch courses. So this one is in particular the one to look out for those of you who are NEET PG aspirants, and I'm sure all of you must be giving NEET PG. So in 2 months this will serve as a good time frame for you, to read your notes along with the live classes. So this is something that you have to look out for, and for this specially we have launched the 2-month subscription where you can just in time for NEET PG, and hopefully this should be the last subscription that you have to buy, and no more extensions or new subscriptions you'll have to buy. And you can use my code if you're looking to get anything, which is ZURA live or just ZURA. So let's begin then with lines and tubes. Alright, so I also want to tell you how they optimally must be placed. Alright, so what is the normal position expected for most of the tubes is also something that we want to discuss. Okay, so the first thing, so there's a table which is showing you the positions of normal positions of all the tubes. Alright, so let's begin with this X-ray here. You can see 2 tubes in this one. Can you tell me what are the 2 tubes that you are seeing here in this one? So there's one tube here. Yeah, so there's one tube here and then there's one tube here. So what are these 2 tubes? The one that you can see centrally within the trachea is the ET tube, right? It's the endotracheal tube, and remember the optimal position, the desired position is 2 to 5 centimeter from trachea. So this you can see basically one vertebral body you can assume is 2.5 centimeters. Okay. So basically you can see 2 spinous processes from the level of carina. So this is approximately 5 centimeters, which is a normal position of the tip of ET tube. And when we talk about the central line here, which is going from the right jugular vein, something which is most commonly used, right IJV as excess, and the tip is somewhere here. When you look at the heart border, the topmost portion of the right heart border is SVC, right? And that is where I want the catheter. The tip should be in SVC, and that is also true for any PICC line. PICC line is what? Peripherally inserted, where we use the basilic vein more commonly, or the cephalic vein, and we insert it and then it goes in. So this is more comfortable, particularly for children, who need it for a longer time. So PICC line can be used where again the tip should be in SVC. On a similar line, so again, what am I showing you in this? If I ask you, what is this device here? So we see that the tip is still in the SVC. So this is one of the central lines, but with a modification. So what is this? This is called a chemoport, right? So this is called a chemoport, and it looks something like this, wherein it has the silicone self-healing sort of film. Alright, such that any injections that you do here would be self-healing, and it reduces the risk of infection. So remember, this has the least risk of infection out of everything, because there is no again and again interference, and entry of staph aureus from the skin gets limited. Alright, so that is why this has the reduced risk of infection. And what is this? When you see a Dacron cuff getting marked, alright, so this Dacron cuff basically is used in tunneled catheter. Alright, so very, very important. Yes, we've discussed this in Midnight Express, isn't it? So a tunneled catheter is something wherein you create a subcutaneous tunnel, and this Dacron cuff basically fixes it to the subcutaneous plane, and this way it can be used for a longer time. Okay, so this way the basically longevity of the catheter increases. So two main purposes, two different names. It can be called a permacath or a Hickman catheter. So it can be used for dialysis, which is the permacath, or it can be used as chemotherapy agent, which is your Hickman catheter. Alright, so both of these purposes are solved by the tunneled catheter. Again, the tip has to be at SVC-RA junction. Okay, moving on to other lines here. What is this that I am showing you here? If you notice, so this is a long catheter, right? It's going vertically like this, then it's taking a bend, alright, and then it's going into one of the hilum. So what is there in the hilum? There's a pulmonary artery, right? So you can see that the tip is within the pulmonary artery. So this is what, when we take a route from RA, RV, RVOT and pulmonary artery, this is a Swan-Ganz catheter, and the tip is in the proximal right or left pulmonary artery. Remember, it is within 2 centimeters of the hilum. Okay, and this is used for the measurement of pulmonary capillary wedge pressure to distinguish whether the edema that you are dealing with is cardiogenic or non-cardiogenic, right? So that is where this comes into play. So remember, the tip has to be in the R or L pulmonary artery within 2 centimeters of the hilum. Okay, so this is Swan-Ganz. When I show you this, pretty easy. First of all, what is the diagnosis? So on the left side, you can see that there is a complete black radiolucency that you are seeing without bronchovascular markings, which indicates the presence of a pneumothorax. And for that pneumothorax, a tube has been inserted, isn't it? You can see these holes. This is an ICD, right? So there's a pleural drainage tube or an intercostal drainage tube, which is ICD. And what is the direction? So remember, when we are putting it for a pneumothorax, okay, we will have antero superior, whereas when I'm putting it for an effusion, I want to point it down, so postero inferior. So this is how the direction of ICD will be different depending on the indication. Alright, so this is for pleural drainage tube. Going on to the next image here, what is this instrument which has a subcutaneous pocket? A lot of things will have this subcutaneous pocket. So you have to look at the leads, right? You have to look at the end leads, and what do you find? That there are two chotu leads. So whenever you see small leads, it is a pacemaker. So remember, you have to count the number of leads to see in which chamber it would be. Most of the times, one is definitely in the right ventricle. Alright, so when you see a single lead, most of the times it's in the RV. Rarely it can be in RA. But when you see two leads, so this is basically one in RV, one in RA. Sometimes it can be a biventricular pacemaker where you have three leads, RA, RV plus LV. Alright, so just count if 1 RV, if 2 RA plus RV, if 3 RA plus RV plus LV. So in this case we have 2, so this has to be in RA, this has to be in the right ventricle. Alright, so this is how pacemaker appears, and how do we distinguish it from an ICD, implantable cardiac defibrillator? It will have these shock leads, right? It will have these large shock leads, and how are they placed? One is in the SVC. Can you see how it's superiorly located in the brachiocephalic vein? It's in the SVC, and the other one is placed in the right ventricle. Alright, so the long one is the ICD that we see. And finally, a few more things about it. So two complications of ICD or pacemakers which are important. So because they have these long leads, right? Sometimes what can happen? What is this? If you see this with a bone, what will you call it? It will be a fracture. Alright, so this is basically one complication which occurs, which is called the fracturing of the lead. So this can be asked to you as an image-based question, that was the complication you're seeing. And something else, people who are very idle, there's one name for them, jo khali baithte hain, twiddlers, right? They keep doing something or the other random thing, they're called twiddler. So this is something which is called as the twiddler syndrome. So you don't have anything to do, you are just sitting and you are playing with your subcutaneous pocket of pacemaker because I have nothing better to do. So what will happen because of that? All your leads get messed up. Alright, so that is called as Twiddler syndrome, when the subcutaneous pocket gets messed up, and that results in pulling out of the lead. Do you see how the lead has been pulled out from the right ventricle? Alright, so that is the complication which is called Twiddler syndrome. So don't be a twiddler, have some work. Okay, going ahead, what is this that I am showing you? So again, to get rid of these complications where you have lead related complications, what can you do? Can I have a wireless pacemaker? So that is the recent advance that I am showing you, right? So this is called as a micra device or a wireless pacemaker. Okay, wherein you just have this detached sort of a pacemaker which is placed in the right ventricle. Alright, so this is placed in the right ventricle. This is a wireless pacemaker. Both of them are complications of ICD as well as pacemaker. Anything which has a lead, both of them will have these complications. Okay. Right, so this is a wireless pacemaker or a micra device where you just place it in the RV and you won't have to twiddle with anything or there will be no fracture. Okay, so this is about that. And finally, one more image that we want to see. What is this? I saw one subcutaneous pocket. When I see two subcutaneous pockets and something is going up in the neck, any idea what is this? What is this? So is NEET PG difficult than UG? No, both are difficult. The better answer would be both are difficult in their own regard, but we can talk more about it later. Right now we are studying CVS. So what is this? Anybody wants to take a guess? कि ये क्या है? Is this cardiac at all or is this something else altogether? Very nice. So this is actually something called as DBS, which is deep brain stimulation. So DBS, basically two very important indications. One is for Parkinson's disease, the other one is for various dyskinesias, dystonias, in fact even for this thing, Tourette syndrome. Now it has been approved, right? So when you see this, the generators are actually placed in the chest subcutaneous pocket, but the leads actually go up and end up in the thalamus as well as globus pallidus. So remember, when we are doing it for PD, the preferred location of the electrodes is where? Important for INI-CET. It's in the subthalamic nucleus. Alright, but when we talk about dyskinesias, Tourette's, we want to place it in globus pallidus interna. That is the more preferred side. Alright, so just remember where the electrodes of DBS go for stimulation. Okay, so these are the two sides and the indications, and this is how DBS can actually mimic a cardiac pacemaker or a ICD, but it's actually very different. Alright, everybody, are you all on the same page so far? Please tell the difference between ICD and pacemaker. I just did, I thought. So, if you find a long shock lead, like this, it is ICD. But if you find these chotu endpoints, that is a pacemaker. Okay, so that is the difference, Divya, between the two devices. Okay, finally, what is this? So this is an NG tube, right? Very easy. The optimal position of NG tube, remember, best is again an X-ray to show the position. The tip should be in stomach and it should be at least 10 centimeters. Alright, so you have to make a loop, otherwise it will come out. So you need to have a 10 centimeter loop within the stomach. That is a normal NG tube position. Alright, so these are the various devices. Apart from that, a few extra edge devices. What am I showing you here? Where you only see one metallic tip within the aorta and everything else is not radio opaque. What is this? This is a intra-aortic balloon pump. So this is an IABP device where the balloon is not really radio opaque, but you have a marker, you have a radio opaque marker. And what is the position of IABP? The position of IABP is actually just 2 centimeter distal to the left subclavian artery. So beyond the origin of left subclavian artery, 2 centimeters below it, the IABP is placed. And how does IABP act? It acts by getting inflated during diastole and deflating during systole. So what will happen? When it gets inflated during diastole, do you agree that the blood, basically instead of going into the descending aorta, more blood will go retrograde, and that way, which vessels will get more blood supply? Which are the vessels which are getting most of their supply in diastole, unlike anything else? What are those vessels? Coronaries, right? So basically what this does is when it inflates in the diastole, the coronaries get more retrograde blood flow, alright? And during systole, it is deflated, so the afterload reduces and more blood can go distally. Okay, so that is the principal mechanism of action of intra-aortic balloon pump, and this is usually used in any sort of cardiomyopathy, ischemic or non-ischemic, when the ejection fraction goes below 35%. Okay, so that is the usual indication of IBP. Apart from that, what is this? Very heavy duty device, Gray's Anatomy, that's a hint. These wires are cut in Gray's Anatomy. So this is a LVAD, right? So this is a left ventricular assist device. It's a very bulky looking instrument. So remember, when you see this heavy load instrument, this is an LVAD instrument. Alright, and apart from that, what is this? So is Divya still here? Can you identify what this is? So when you see these long leads, these are ICD, right? So these are implantable cardioverter defibrillators. Along with that, you have LVAD in this particular X-ray. Okay, what is this that you are seeing here? Placed superficially in the subcutaneous pocket anteriorly. What is this called? So So this is something which looks like a pen drive, no? Doesn't it look like a pen drive has been inserted into your body to get some chips, I mean information, aisa kuch kuch. So this is basically something which is called as an implantable loop recorder. Okay, so what happens when you have arrhythmias, all right, and you want to monitor the patient? If you just want it for 24 hours, if your arrhythmias are recurrent, they come within 24 hours, you can do a Holter monitoring, right? So Holter monitor is usually for 24 to 48 hours. So you can put a Holter monitoring. What, Saundarya, I didn't understand your question, just thoda or elaborate. So Holter monitor is used for 24 to 48 hours. All right, but what happens if you want a higher recording? You know, your arrhythmias are not very frequent. Then you can use external loop recorders which can go up to 4 weeks. But वो भी नहीं चल रहा, arrhythmias are very rare, almost monthly. Then what to do? Then you can put these pen drives into your cells, which are implantable loop recorders, which can be for 3 years. So in those 3 years, your entire rhythm gets recorded, and you can pick up those incidental arrhythmias. Alright, so remember, these are the 3 kinds of monitoring devices for ECGs. Okay, so yeah, this is your, just remember, pen drive, and it is implantable loop recorder, which is implanted as the name suggests. On the other hand, the other 2 are placed subcutaneously. Okay, it doesn't really have chances of infection if placed with sterile technique. You know, it's like anything else where it doesn't really lead to infections. Okay, alright, so going on to babies. In babies we put umbilical lines. So very important to understand what is umbilical venous, umbilical arterial. Just one trick to remember, you know, that if it dips like this, it is arterial. So the gray arrow is showing you an arterial catheter because of the insertion. The table isn't clear on screen. Can you please? Yeah, I'll post the PDF. I'll post the PDF on the group. Okay. Yeah, so what was I saying? Apart from that, if it's not clear, just increase your resolution of YouTube video. That probably helps a lot of times. Okay, yeah, so this, when it takes a bend because of the iliac artery taking a bend here, that is umbilical arterial catheter. On the other hand, when it goes straight like this into the ductus venosus, this is your umbilical venous catheter. Okay, so this is how we basically identify umbilical lines in babies. So this is about lines and tubes. Apart from that, a pacemaker, and you have prosthetic valves. So how to identify prosthetic valves? You basically mark out the left hilum and you draw a line towards the right cardiophrenic angle. So draw a line connecting right cardiophrenic angle to the left hilum, and anything above, A for above, A for aortic valve, anything below, M for mitral valve. Alright, so most of the time these are the 2 most commonly placed valves. So aortic and mitral. If it is a third valve, if you see a third valve, then again see whether it's up or down. If it's up, it's likely to be pulmonary. If it's down, it's likely to be tricuspid. Okay, so most of the times you find A or M, and that would be your question. Okay, so this is about all the various lines and tubes and devices about CVS that I wanted you to know. So now going on to the coronary anatomy. So when we talk about coronary anatomy, where do they arise from? They arise from the aortic sinuses of Valsalva. Alright, so we all have 3 sinuses of Valsalva, wherein one is anterior, 2 are posterior. So from the anterior cusp, the anterior sinus, we have the right coronary artery which is arising. Alright, so right coronary artery arises and it runs between RA and RV. Okay, it runs between RA and RV. Yeah, so those are the wires. Alright, so yes, that's the normal course of DBS, Saundarya, where from the brain through the neck the pockets are placed into the subcutaneous chest. Alright, so that is the normal course. Okay, yeah, so anterior में से RCA निकल रहा है. Then on the left side, from the left posterior one, we have what? We have the LCA, and remember the right posterior one is the non-coronary cusp, right? So no vessel arises from this, so this is called as the non-coronary cusp. Okay, so this is how the coronaries are originating. Going further to the course and the various branches. So remember the right coronary artery, as you can see in the schematic, is originating slightly inferior. The origin of RCA is slightly inferior to left coronary artery. Then what does it do? Where does it run? So it runs between RA and RV. So it runs in the right atrioventricular groove. We'll come to Al-Kappa, we'll come to it. First we study normal, then we go to anomalies, right? So it will be running in the right atrioventricular groove. Alright, everybody. So this is the course, and it gives rise to 4 branches. Okay, 4 branches which are CAMP. You can remember CAMP, you can remember CAMP. So C for conus branch. So the conus branch basically supplies the right ventricular outflow tract. Alright, so the RVOT basically is supplied from right coronary artery. What is A? What is A? A is the AV nodal branch. So the sinus branches, AV nodal as well as SA nodal branches are going to arise from RCA. In 65%, remember, in the other 40 to 35% cases, you can have basically this arising from left coronary artery, but more commonly it is RCA which gives rise to this. Then, which marginal? The main ones are AM. So remember, CAMP, AM. This is going to be acute marginal. Anytime you hear the word marginal, what will you say? The marginal one supplies the free wall. So the free wall of right ventricle is actually supplied from the right coronary artery. And P for what? What is the branch? This is the most important one, which is the posterior descending artery, PDA. And that is what is going to determine what? This is what is going to determine the dominance. So PDA का इतना importance क्यों है? So the importance of PDA is in the fact that it will supply what all? So it supplies the posterior 1/3 of interventricular septum and posterior wall of LV. So posterior descending, right? So posterior wall of LV as well as posterior 1/3 of IV septum. And remember, in around 80% this arises from right coronary, which we say that it is right dominance. In 15% cases it arises from left coronary artery, तो left dominance हो गया. And in around 5% cases दोनों contribute करेंगे, it becomes codominance. ठीक है, तो ये है अपना PDA. Alright, so this is about posterior descending artery and what supplies the posterior aspect of the heart. ठीक है? Going ahead. So now going on to the left coronary artery. So the moment left coronary artery arises, immediately, जैसे ही arise हुआ, immediately it will divide into what? It will divide into LAD and the left circumflex artery. Okay, so LAD or left circumflex artery में वो divide करेगा. And what are the branches of LAD? What are the branches of LAD? So the branches of LAD are going to be the 2 main branches. Alright, so 2 main branches which is going to be diagonal as well as septal branches. Okay, what are they going to do? So septum is going to supply the 2/3. पीछे का तो PDA का हो गया था. So anterior 2/3 of the septum by septal branch and diagonal branch anterior wall of LV. So we've already done anterior wall of LV, posterior wall of LV as well as complete septum with the help of LAD and PDA. Now what are we left with? We are only left with one thing, which is free wall of left ventricle, right? So free wall of left ventricle, again, anytime I use the word free wall, it's going to be arising from marginal. It's going to be supplied by a marginal branch. In this case, it's going to be obtuse marginal, which is a branch of left circumflex. Okay, so this supplies the free wall. Is this clear? So if I have to take a cross section, if I take a cross section of the heart and show you this segmental approach, इसको बोलते हैं segmental approach. Can I say that this is how I'm going to divide the various walls of the ventricles? So what was about PDA? PDA, which is a branch of right coronary artery, in most cases was supplying what? Posterior 1/3 of the septum, that you can see here, right? So posterior 1/3 of the septum as well as posterior wall of the ventricle. So सारा posterior descending stuff is getting supplied by RCA. Then when we go anteriorly, 2/3 of the septum as well as anterior surface of LV getting supplied by LAD. And what is the only job of LCX? Obtuse marginal, so free wall. The lateral wall is going to get supplied by this. So based on the ECG localization, can I actually point at the culprit vessel? Answer is yes. Similarly, on MRI, when I am taking a cross section of MRI, can I again point out the culprit vessel based on the area which is affected? Is this clear, everybody? So this is the anatomy and the supply of the heart. Alright, so coronary artery anatomy and supply, very, very important. Going ahead to a few anomalies, to a few variations. So now look at this particular image. What is happening? So we have the anterior cusp, which is giving rise to RCA also, which is giving rise to LCA also. So what is happening to bichara LCA here? Origin to ho gaya, SA node again RCA, right? RCA is going to supply the SA node in most cases. So what are we having? It's coursing between the aortic, basically the aorta as well as pulmonary artery. So can I say it has an inter-arterial course? What are these major arteries going to be? Are they going to be pulsatile, very, very pulsatile, and this coronary is coursing between them? Do you think this has very high chances of getting obstructed? Yes. So that is why this inter-arterial course is also called as the malignant course. Alright, so this has very high risk of LAD or left coronary artery getting compressed. Okay, so this is one of the most common congenital anomalies of the coronary arteries, and this is called as inter-arterial or malignant course. On the other hand, there is one more very, very deadly complication, one more anomaly, which is called Al-Kappa. As the name suggests, it also has this very complicated name called Bland, Garland and White, which you can remember if you want. But Al-Kappa is very self-explanatory. But what is happening? Anomalous origin of what? Of left coronary artery. From where? From pulmonary artery. So here LCA, instead of arising from aorta, is arising from pulmonary artery. So what will happen here? When LCA arises from MPA, there is going to be a coronary steal phenomenon. Remember, we studied subclavian steal yesterday night when we were discussing the tough 20 quiz. Here there is coronary steal. But what is going to happen? There is going to be a left to right shunt, right, where the coronary artery is going to send all of its blood from pulmonary artery. Or on the other way round, you can also argue that the left coronary artery, because it's arising from pulmonary artery, is getting relatively deoxygenated blood. So what will happen when it presents? When it presents in infants, it is going to present as infant MI. So when you find infant who is dying with myocardial infarction, Al-Kappa remains the most important possibility. But if it is not very, very severe, infant has adjusted, you grow into an adult, it will present as pulmonary hypertension because now it starts to steal the blood. Right? So slowly it will present as pulmonary hypertension. So remember, in children, infant MI, whereas in adults it presents as pulmonary hypertension. So when you are diagnosing this in children, you do a Takeuchi procedure. Alright, so remember some Japanese procedure, Takeuchi procedure, wherein you will reimplant. Alright, whereas if you are presenting as adult, you can do a CABG procedure where you can just ligate this and do a CABG with INA or great saphenous vein. Okay, so this is about Al-Kappa, slightly extra edge but important for AIIMS. So anytime you hear an infant who is having MI, think of Al-Kappa. Okay, is everybody with me so far? Are we all good to go? So this is about coronary artery. Quick word about Agatston scoring. So this is something which is called as calcification score. Alright, so coronary calcification, when you want to see that how many coronaries are calcified, tell me, for calcification, do I need a CCT or NCCT will suffice? What is the investigation of choice? We want to look at calcification. NC, right? So we're going to be doing a non-contrast CT here, and the non-contrast CT will determine, it will tell us the area of coronaries which is calcified, and it will actually calculate the Hounsfield unit. Will that tell me how densely the vessels are calcified? Jitna zyada HU hai, will I know how much densely it is calcified? Yes, I will. Okay, so basically the highest value plus the volume, everything gets summed up and you give a score. What are the indications? So asymptomatic patients, intermediate risk. Can I do it for prognostication? कि जितना ज़्यादा calcification है, poorer is the prognosis. So it is used for prognostication. Second, in patients who already have symptoms. So if I tell you what is the investigation of choice to study coronaries, if I want to see how much atherosclerosis is there, what is the best investigation? It has to be a contrast study, right? It has to be a CT angiography. So why am I doing an NCCT in patients who already have symptoms of angina, of acute coronary syndrome? I can do it as a screening tool before further investigations or before CT angiography, or I can use it when functional testing is not possible. Patient cannot exercise, stress pharmacologic agents are contraindicated, I can do this. So just remember, it is done before CT angiography and it is also used as prognostication. Higher the score, poorer the prognosis. So this is about the Agatston's score of coronary calcification. Is this clear? Everybody, what you need to remember: one, NCCT is used. It determines the prognosis of the patient by determining the calcification of coronaries. Okay, right. Now going on to cardiomyopathy and the various features of cardiomyopathies that I want you to know. So What is this? So now we are going to be first one-liner for cardiomyopathy. What is the investigation of choice? This is just something slightly extra. I just want to orient you over before INI-CET, okay, because you can be tested. So what is the best investigation to study cardiomyopathy, whether it is ischemic cardiomyopathy post-MI or it's non-ischemic cardiomyopathy, which we know as dilated, restrictive, HOCM, MRI. Wonderful. So now are you ready to see some MRI images? Yes? Even if you are not, you have to see. So what are we seeing here? So this is something which is called as late gadolinium enhancement. We talked about it yesterday. So late gadolinium enhancement is very good to pick up what? It is very good to pick up ischemia. It is very good to pick up infarcted tissue. Why? Because the myocardium, which is not viable, which is not perfect in health, will not be able to excrete out the gadolinium. It will take, but वो बाहर नहीं निकाल पाएगा. So there will be retention when late. So when I take an MR after 10 minutes, बाकी सारे perfectly healthy myocardium will take out their own contrast. But these scarred ones, these ischemic infarcted myocardial cells will not be able to excrete the gadolinium, and that will be retained. So I am showing you this sectional view of the heart, wherein we are seeing that if this is the total myocardial wall, can I say that there is subendocardial enhancement here? Can you notice subendocardial enhancement? So any ischemia, how does it start? So any ischemia is going to start as subendocardial, right? So this is subendocardial ischemia, and slowly, if left untreated, what is going to happen? It's going to turn into what? It's going to turn into a transmural infarct. So both, depending on subendocardial or transmural, we will see the enhancement. Is this making sense? So whether you see subendocardial enhancement or transmural enhancement, you will know what kind of an infarct it is. So this is the use of ischemia. Apart from that, if I see subendocardial enhancement in a case of restrictive cardiomyopathy, walls are thickened, not ischemia. Restrictive, which shows me subendocardial enhancement. 1DD, one infiltration which affects subendocardium, subendothelial blood vessels, pinch purpura. What is that disease that we've studied? Amyloid, right? So amyloidosis, most common cause of RCM, remember, will also show us subendocardial enhancement. And one more condition, one more connective tissue disorder which can also show you subendocardial enhancement, remember, is scleroderma. So scleroderma can also show you subendocardial enhancement. Sarcoidosis is typically mid-wall. So if this is the wall and you find a mid-wall enhancement, think of sarcoid as a cause of restrictive cardiomyopathy. Alright, so slightly extra information for you. All of these are causes of cardiomyopathy. Okay, is this clear? So subendocardial, infarct or ischemia, amyloidosis, very important, and rarely scleroderma, if you want to remember, good enough. Okay, so this is about cardiomyopathy. Now, when I show you this sort of an echo appearance, see this, what is happening? Look at the septum and look at the thickness of the left ventricle. This is a 4-chamber view that I am showing, that these are thickened. LV is more than 15 mm, septum more than 12 mm. You don't really need to remember. What is this? This is hypertrophic obstructive cardiomyopathy. If I show you cardiac MR, see this, let me just erase this. See this cardiac MR. So remember, MRI again can be dynamic, right? We can take these dynamic sequences. So see this for me again. So this is a 4-chamber view where I want you to focus here. Focus, can you all see the video which is playing? So focus your attention on this area. Let me just label it for you first. So this is basically the left ventricular outflow tract. Alright, so this is the left ventricle here, and this is where the aorta is coming out. So I want you to look at this wall here. What must be this wall which is connecting the LA from LV? This is the mitral valve. So what is gonna happen with the mitral valve is, in the systole, it's gonna show you the anterior motion. Very important, which is called SAM, systolic anterior motion. So now just focus on these areas. Alright, I'm playing the video and focus here. So can you see, once it starts to play, that there is this anterior motion of the valve, anterior motion, which further causes what? Which further narrows this LVOT. So in HOCM, the main problem is what? Can I say that the blood is not getting pumped out from LVOT because septum is banana shaped, LV is hypertrophied plus the mitral wall is going anteriorly. And because of that, LVOT is pitch good. So where will blood go? Tell me. Will the blood regurgitate? Will there be mitral regurgitation? Can you all see that? Let's try and observe. Can I see mitral regurgitation on MR or not? Let's see. So try and see the motion of the blood. So this is how blood is going. Can you see how in systole that is actually coming back? Can you see this? It's coming back. So you can also see mitral regurgitation. So this is actually what happens in HOCM in loop. Okay, so in systole too much stuff is happening. Systolic anterior motion of mitral wall further narrows the LVOT plus you have mitral regurgitation. Alright, so that is the pathophysiology of HOCM. Alright, so this is about HOCM. Is this clear? Everybody, can I move on? So this is about hypertrophic obstructive cardiomyopathy. On the other hand, when you have thickened walls like this, very thickened walls, and see the enhancement, subendocardial enhancement. Can you tell me the diagnosis now? Thickened walls resulting in reduced ejection fraction. What is this? This is restrictive cardiomyopathy, and when I see subendocardial enhancement, most common cause of RCM, I think of amyloidosis. Alright, so this is what you have to remember for RCM. Okay, going ahead. What is happening here? All the chambers are dilated. So when you get a combination of dilated chambers plus reduced ejection fraction, what is this? This is dilated cardiomyopathy. Consider alcohol, Chagas disease as well as peripartum cardiomyopathy. Alright, so three very important causes for exam. Peripartum cardiomyopathy usually presents as DCM. And something very interesting. Here, look at the right ventricular wall for me. So this is RV, this is LV. This is normal LV wall, right? Normal LV wall, normal septum. Look at what is happening to the RV free wall. Do you agree? Something which is resembling fat. Fat is hyperintense on T1, T2 both. So fat is hyperintense. Can I say कि इसकी wall में, which had to be muscle, there is fatty infiltration. So when there is fatty infiltration of the when there's fatty infiltration of the right ventricular free wall, which is also a video that I want to show, and the wall is very hypokinetic. See how irregular it is. You know, can you see the irregular beating of this? Wait, I'll just... Yeah, so try and see the very irregular beating contractility of RV. What is this? So this is arrhythmogenic right ventricular dysplasia, right? So this is ARVD, which has two types. One is fatty, second is fibrofatty, right? So it can be fatty or fibrofatty, and this is the white fat that you can see in the wall, and see the hypokinesia and the akinesia, which is why it's called as arrhythmogenic right ventricular dysplasia, right? So this is something which is important. Going ahead to the next image. So finally, the one thing where they'll show you this octopus spot on a angiography, because everything else will tell you that this is myocardial infarct. You will find that troponin is raised. You will find that ECG abnormalities are there. You would consider it MI. But what is the difference? There is a stressor. There is a stressor, and when you do the angiography, there is no coronary disease. There is no plaque. What is this? This is octopus heart. This is Takotsubo cardiomyopathy. So remember, this is because of sympathetic overactivity. So always rule out pheochromocytoma. Also rule out myocarditis. And the problem will be with the left ventricular wall, where it is hypokinetic or akinetic. Okay, so this is about Takotsubo. Because of the left ventricular hypokinesia, it assumes this shape on ventriculography. Okay, so this is Takotsubo, and we use the Mayo Clinic criteria. Where else do we use Mayo Clinic criteria? Lots of places. But my favorite thing in the world, IgG4, right? So remember, IgG4 disease is also Mayo Clinic criteria. Apart from that, for CA endometrium also, to determine left this thing, lymphovascular invasion, we also use Mayo Clinic. Okay, so काफी जगह Mayo Clinic आता है. What is this? Just on a different note, not a cardiomyopathy, but a question which can be tested. A patient comes to you after trauma, after a road traffic accident, and you see this kind of an appearance. You did E-fast, and this is what you are finding. Is it fast positive, fast negative is my question. So we have put the probe in the subxiphoid, right? The first area in fast that we look at is the epigastrium or subxiphoid, and this is what I am finding. So yes, This that you are seeing here is basically the pericardial effusion. So this is pericardial effusion. This is fast, positive. So do not miss pericardial effusion. You will see the heart, and around the heart you will see this kala anechoic fluid. Okay, so this is about pericardial effusion. So I think we can stop. This was supposed to be a 30-minute class, but it's become at least 40 to 45 minutes. So I'm sorry for that. But I'll see you all again today at 8 p.m. Alright, so tonight at 8 p.m. we are going to be meeting for exam strategy session, something that I want all of you to attend, how to attend the INI-CET paper and give your best attempt. So thank you so much. I'll post this PDF if you want. In fact, I'll post the PPT. I don't know if I should do that, but I'll just post these videos, in case you want to see. Thank you, Arjuna. So yeah, so I will see you all at 8 o'clock, and then 10 o'clock we have one more YouTube live. You can see it live, or you can see the recorded version where we'll be talking about all the one-liners. Okay, so just to get that sorted, all the maximum permissible doses, radiation units, all the Rattamaro stuff from radiology. 10 o'clock tables, nuclear medicine especially, because I don't know why everybody struggles with nuclear medicine, although not very important. So फटाफट we will do this. Okay, A to zero syndrome, A to Z syndrome बंद नहीं किया, अभी करेंगे. I was not finding the time only to record, but tomorrow onwards I'll start again. Okay, so बंद नहीं हुआ. I was just struggling for time, तो कल से फिर से I'll be more regular. Okay, alright guys, so I hope this is useful, and thank you so much. हाँ, tamponade भी ऐसे ही दिखेगा श्रद्धा. So tamponade versus effusion on radiology will be just fluid, right? So now you have to look at the dynamics, the hemodynamic status of the patient, and that will tell you basically whether it's tamponade or it's effusion, right? So that's a clinical thing. Okay guys, so bye bye and have a good day, and see you all at 8 o'clock.